Hello. Thank you for joining us tonight for regain control of your bladder concerns. We really appreciate the fact that you're taking some time to explore what steps you can take to regain control of bladder problems. My name is Kristen Smith, and I am the moderator for this evening. I'm an outreach specialist at Oakdale ObGyn, and for those of you that have taken other webinars, you've probably seen me around a little bit. You've also seen Andy Meyer, who is joining me as our technical consultant. You may not know that November is Bladder Health Awareness Month, and it's kind of the genesis for this October webinar. We want to be able to bring people information that they can start using to create an action plan for what they might do to deal with any bladder concerns. The thing that's really interesting about Bladder Health Awareness Month is it's really an acknowledgement of the fact that there are so many people that deal with bladder concerns, and it just doesn't have to be that way. You don't need to be wearing pads. You don't need to be wearing underwear. There are medical, surgical, and very conservative things that you can do. There's just the realm of possibilities for treating bladder concerns is pretty cool. And for people that are joining us tonight, wherever you are on your journey, really our goal is to make you aware of what all the treatment options are, make you aware of resources that are available for you so that when you want to take the next step, you kind of have a little bit of an action plan. Relative to housekeeping for this evening, the handouts for tonight are on the website, and Andy will put them in the chat box down below if you want to follow along. Our plan is to do some overview for a variety of different things that can cause bladder problems, and then to spend more time on treatment and answering questions. There's more than 100 people that are coming together this evening to hear the content. We've only got an hour. We're going to do our best to get through as much as we can. If you have to buzz out, or you think that you want to rewatch this, or you want to share it with somebody, it will be available on the website later on this evening or first thing tomorrow morning. And with that, I'm going to introduce tonight's presenters. We have Dr. Matthew Palmer, who's the medical director of Oakdale ObGyn's Center for Urinary and Pelvic Health, and he's joined by his colleague at the center, Dr. Hilary Frank. Each bring advanced skills and training to our topic this evening, and they're really well suited to answer your questions at the end of the presentation. So with that, I'm going to turn it over to Dr. Frank.
Hi, everyone. Thank you so much for choosing to spend your Tuesday night here with us. I do have to apologize. I have a little bit of a cold I'm getting over, so I'm sorry if I have some sneezes or coughs coming out while we talk, but glad you could make it. We can go ahead on to the next slide. We're just going to do a quick, brief introduction into just the overview of what we're going to be talking about. So, just a little introduction to urinary incontinence. We'll talk a little bit about anatomy, just mainly to help you get oriented when we talk about treatment options. And then I'm going to be talking a little bit about stress urinary incontinence. Dr. Palmer will talk about overactive bladder. And then we're hoping to leave as much time as possible for questions and answers. Next slide. So again, the definition of urinary incontinence. So a lot of people think it means you have to be leaking yourself. And that's the common thing, but actually a lot of it can be what we call dry incontinence as well, where you aren't leaking, but you're doing different things with your life to try and make sure that you don't leak. So, so you're making sure you know where the bathroom is, or always having to wear a pad, or, do something different with your life because of that. Risk factors is a whole bunch of different risk factors. We'll probably go into that when we dive into the specific types a little bit more. Same thing with causes. And the two types we're going to be talking about, like I said, will be the stress urinary incontinence and then the overactive bladder. So next slide here. So just a quick overview of the anatomy. So as you can see here, I wonder if I can, I'm going to move the, see, okay. So you have the kidneys here, that's what's making your urine. And then these long white tubes on the left side here, or not white, I'm sorry, yellow, is the ureters, and that's what's bringing the urine that the kidney has made into the bladder. Then, as we all know, the bladder is what holds that urine. An important thing that you're going to hear us talk about a little bit is the urethra. And the urethra is the tube that is how the urine exits the body from the bladder. And that'll be an important structure for when I talk about stress incontinence. On the right side is just giving you a little bit of an orientation of where all the structures are. So you have the front to back, and in the front is the bladder, in between is the uterus, and then in the back is the rectum. So go ahead and do the next. All right. And like we said, women of all ages, they can be affected. A lot of times people think this is just something for older women. But I think Dr. Palmer would also agree with me. We actually see a lot of patients that are in their 20s and 30s with who are having symptoms of this as well. And like this is 1 in 4 are younger women. So a lot of people, I think that keeps them from wanting to come in and get help because they think it's just something that's supposed to be for older people and they get embarrassed, but it's actually very common. Do next slide. So diving in a little bit. So talking about stress urinary incontinence. This is the type of incontinence where you are having little bits or sometimes a lot of leaking with different types of activity. And that's usually coughing, running, sneezing, jumping, any exercise if you're doing like sit-ups or, jumping jacks, that kind of thing. That's when we'll hear patients talk about, leaking out. And a lot of patients, if they know they might leak, they'll do things like cross their legs or prepare for it. Next slide here. Okay. And so the question often is, what can be done with this? And the way I always describe stress incontinence is that this is a structural issue. And so think of the urethra, which is that tube where the urine exits the body. In women who don't have any leaking, it's very well supported. Meaning, I think of that as if you think of a hose that's sitting on cement, when you're doing things like jumping or laughing and putting pressure on that hose, it's kind of like kinking it up against that cement. So there's that good support so that flow of urine, or in the hose example, water, can't leak out. So women who are leaking, instead of it being well supported by cement, something that's firm and you can kink it off, instead what it is think of it as like sand. So it's like hose on the sand, and you're trying to kink it off, but it's just really hard to because that support is too relaxed. And so a lot of the treatment options are going to be built at trying to build up that support, and support that leaky valve that you have there. Some can be lifestyle changes. We do know that having some weight loss can help because that decreases the amount of pressure that you're having on that urethra, so that urine isn't leaking out as much. And another thing that we'll talk to patients about is muscle training. This is always really nice because it's not very invasive, and so patients who don't want to do surgeries or procedures, it's a good option. Another one is an incontinence pessary, which is what this picture on the far left is showing. And so that's a device that goes inside of the vagina. And you can see there's a little blue knob at the top there. And that's actually physically causing that support so that the bladder has something that you can kink it off, or, to help with that leakiness. Bulking therapy is another procedure that I'll go into a little bit more in more detail. And this is a nice procedure because it's very effective, but not very invasive in terms of there's no incisions or anything like that. And then there's surgical options as well. So we're going to go into that a little bit more. If we can go to the next slide here. Okay, so just a quick note about the pessary, because this is something a lot of patients don't know a whole lot about. So it's a vaginal insert, like you can see here, and it has this little knob that is what sits right underneath the urethra. And so this is trying to build up that like cement on the hose so that when you are jumping or laughing, it can kink off and support so that urine doesn't sneak out. It comes in all different shapes and sizes. And what you would do is you would make an appointment with us if you chose to do this and do a pessary fitting. And we try and find the right shape and size that's going to work for you. I will say studies show that about 50% of the time it works, which is great. So that means half the time people find a really great fit that works and that they like, and the tissue is able to handle it and doesn't get irritated from having that in there. But that also does mean that 50% of the time it doesn't work. And the reason why it might not work is since this sits in the vagina all the time, sometimes the tissue will have a reaction and patients don't like that. Sometimes we just can't find a good fit, and so it comes out or it's uncomfortable. And then other times what we'll notice is it just doesn't help with the symptoms like you are hoping for. But it's a nice option if you don't want to do anything that's procedural, but you want something to, give you a quality of life and help with all of that. We'll go to the next slide here. And so we talked a little bit about physical therapy. This picture is Sheree. She's our wonderful physical therapist who does therapy with patients, especially focusing on pelvic floor health. And so she's going to work with you on doing different exercises to really build that support up and help with finding ways that you can support your pelvic floor and your bladder so that when you are doing these kinds of movements, it's not leaking out. Again, a lot of patients like this because it's, again, not very invasive. And so it's a good option if you don't want to do procedures, you want to see what some of the more conservative measures are. She's also very honest. So if she feels like it's not going to quite get you to your goal, and you might need to think about something a little bit more procedural, she'll let you know. And so that's another thing that I think she's very honest and real with patients about, what treatments are going to meet the goal that you are looking for.
I was just going to say something too quick, Hillary.
Yeah.
So, what I think is important about PT to realize that it's not just like something you have to try and fail that, and then you go on to the next treatment. It's really a kind of a interwoven therapy throughout the journey of dealing with pelvic floor. And so a lot of our patients are doing pre-op PT, post-op PT, circling back with Sheree on things, years later after surgery, working on more effective control of their bowels. And there's all kinds of different things, that are related that aren't just, it isn't sort of just like a step in the chain to get to surgery, essentially. So I just really want to emphasize the importance of PT throughout the journey that people are on.
Yeah, I think we both use it fairly heavily, whether a patient wants to do, a pessary or a sling or, whatever, because it's all very connected. So she does a good job of being able to, like Dr. Palmer said, putting it all together.
Yep.
Yeah. Okay. So then we can talk about the bulking therapy. The bulking therapy is something that Dr. Palmer and I both do, and I think it's a really nice option for patients who want something that's going to be effective quickly, and it will give you a significant reduction of your leaking. Now, I do usually tell patients it's not the best option if you're looking to be leak-free, but if you're looking for something where it's like, I'm only leak when I am completely full and have a really hard laugh, then I think this is a good option. It definitely gives you an improvement of your quality of life. And the nice thing is it's something that we can do in the office, and it's fairly quick and it works right away. So what this looks like is patients will come into the office, and what we do is we actually put a little camera inside and can see the urethra. And this is fixing that leaky valve by adding some support. We inject little cushions around, and that helps support and bulk up that area so that that urine cannot leak out quite as easily or at all. Now, a lot of patients think that sounds like it could be fairly painful, and surprisingly, I find people tolerate it really well. We definitely give you some medication to help with pain control. I would say overall, it takes about maybe 10-20 minutes to do the whole procedure. And the nice thing is a lot of studies are showing that it works for about 5 to 7 years. This says every 1 to 2 years, but that is not correct. So usually it actually works longer than that. There's a small percentage of patients where after they have a treatment, within that first year, they might need what we call a top off, where they might need to come in for just one other injection just to help a little bit, bulk that up again. But a lot of patients are getting a longer term benefit. So it's not something you're having to come in continually and have done over and over again. And the nice thing with this too is there's really no restrictions. So it works right away, and you're not having to, be careful with lifting or movement or anything like that. You can go back to your daily activity pretty quickly. Very safe procedure. The stuff that we use to inject it is mainly water, which is also pretty nice that patients like. It's not some foreign body material that you're going to react to. it has lower success rates than surgery. And I would say that's probably one of the larger cons to it, but it is definitely more successful than not doing anything. And a lot of patients I find are very happy with the results from that. Do you have anything to add?
I think it's really a distinction for most people between doing something that is, really a no downtime procedure, knowing that they may compromise the success a little bit compared to a surgical or like a sling approach, but it could be a great procedure for many people that don't really have the time to recover at all, and they want something that's going to work for them right now. So that's what I like about it.
The other niche that I find that's nice for is some patients that are younger and are not wanting to, have to say, well, I'm done having children, but I definitely don't want to keep leaking like this. Some patients after their first pregnancy, they notice they're leaking all the time, but they want to still expand their family. This is a really good option for that. It'll help during that interval. But it's still compatible with future fertility. So I think it's good for that patient population as well.
Yep, good point.
So next. And then the last option to talk about is the bladder sling, or that's what is commonly called. And there's 4 different ways to do this bladder sling. I think the one that Dr. Palmer and I both do the most, I think I do this in like 90% of my patients, is actually a single incision sling. And so this one's a really nice option because it's just one little incision. It's about 1 to 2 centimeters at the top of the vagina. And it uses the littlest amount of mesh, and it goes through the smallest amount of tissue compared to the other 3 types of slings without compromising the effect of it. And so because of that, this does have a little bit more recovery time and a little bit more soreness, but nothing compared to some of these other ones that go through more tissue and there's more dissection involved. I would say in my experience, most patients after a few days, they are up and moving around and not noticing that they even had any issues with it. That one little incision usually gives them some soreness for a day or 2, but nothing too terrible. And then the other thing that's really nice is this is anchored into the tissue by little anchors. And so it has very little restrictions after. So you can go back to your daily life fairly quickly. What it does is it's a little piece of mesh that looks, I think of it as like a piece of Scotch tape that goes just underneath that urethra and is physically adding that support. And we know this is pretty much the most effective option. I would say it is around, studies are saying 85 to 95% effective up to 10 plus years. And most patients, in my experience, have leak free. And so that's what they really like about this. This is a nice option for if you want the thing that's going to help you with minimal amount of recovery needed, and it's just going to give you your life back very quickly. This is a good option. It does involve mesh. So I know that's become a new concern because of a lot of the bad press with mesh out there. I would say it's something that's been used since the 70s, a little older than that. The mesh that we use, I think of it as being similar to putting in any foreign body inside. And so there's always that risk and concern that it could get infected, or the tissue could react to it, just like if you had a pacemaker or a hip or mesh for hernia repairs. But the risk of that happening is very, very low. So that's the nice thing with this surgery. It's still a day surgery, but it is still surgery. So it's something where you would go under general anesthesia. But I would say it's very minimally invasive.
I think as you think about mesh a little bit too, you have to kind of put it into context. And back in the heyday of when people were doing a lot of transvaginal mesh, probably like 20 years ago. First of all, just about every gynecologist was doing these procedures, whether or not their volume indicated that they probably should be or not. And then also people were probably were for sure placing larger sheets of mesh into the vagina to kind of hold the whole vagina up, almost like like surrounding the prolapse all over the vagina with mesh. And I think what we really saw is that that's a really bad idea, that your body tends to want to reject that approach. And that's where a lot of the erosions and the complications came in. So now we've really dramatically reduced the footprint of the mesh, and also the build of it is different too. It's a lot more wide pore.
Yep.
It's a lot more integrated into the tissue and allows for the tissue to kind of grow into it. So it's not rejecting it or building a capsule around it so that it spits it out. It's more of an integrated kind of thing. And so it's not, you can't really put all mesh into one bucket and say it's all bad. You have to kind of understand it, and you have to kind of talk about the why of it and understand, what it is and who's doing it for you. And that makes a big difference, so I just I like to share that with patients when they kind of have some concerns about mesh, and we talk through that in some detail like that.
I agree.
All right. Well, nice job, Dr. Frank. And certainly, we want to leave a lot of time for questions, and, we're trying to I would say, cover the therapies for different things really well so that it generates questions for you guys. But we want to, I know there's people that don't just have one thing. Some people have mixed incontinence where they leak different times, sometimes with coughing, lifting, and seizing, sometimes other times like with urge. And so it's not really a one size fits all problem. And so we want to just give you information and then let you guys ask questions. So I'm going to talk about overactive bladder and urge incontinence. And this is kind of referencing more of a nerve and muscular and smooth muscle problem rather than a structural physical problem like prolapse or like the urethra hypermobility like Dr. Frank was talking about. This is a problem where the brain is telling the bladder to contract and spasm when it shouldn't be. And patients often experience the sensation that they have to void and they're not going to make it to the toilet on time. Patients often will have triggers where they feel like they're in a certain scenario where they know that there's a toilet just beyond that door when they're coming in the garage, and it's instant, they got to go and they may not make it in there. Patients often describe scenarios where they're worried about going out. They're worried about where the bathrooms are and what's going to happen if they can't make it. And essentially it can be looked at as constant or chronic urge, and with or without leakage. And also a lot of times people experience nighttime symptoms. So they're getting up frequently at night. Their bladder is telling them, every hour or two that they got to wake up and go empty. And many times people tell us that they don't really get that much out even, but they feel like they have to go that frequently. So these are kind of the common descriptors of overactive bladder, kind of distinct or separating that out from, more of the leaking with activity. So go ahead to the next slide. So some of the things that we're going to address in more detail, I'll go through the list here, are basically lifestyle changes. Sometimes there's the thing that we'll always address with patients is, what and when are you drinking certain things? Like, are you drinking bladder stimulatory drinks, that are like 25 cups of coffee a day or something like that? Are you drinking a lot of caffeine? Are you drinking a lot of carbonation? Are you drinking too much, too close to when you're trying to go to bed and you're waking you up all the time? And, so simple things like that can make a difference. Things like weight loss is also an important factor for some people. And, we don't want to underemphasize the fact that carrying extra weight can make it more difficult for you to control your bladder. And so that's an important factor in lifestyle changes. We're going to talk about the physical therapy and the muscle training. It's not like the same kind of thing as doing like Kegel exercises, like you would be working on when you're doing, stress incontinence treatment. It's more of bladder retraining. So a lot of times patients can be instructed on how to sort of talk to their bladder in a way that their bladder doesn't control them, but they control their bladder. And it's sort of a repetitive process of kind of retraining your bladder as to when it's supposed to empty. And that can be, again, of course, in conjunction with other more directed therapies, but it's part of the story of success. And then we'll talk about medications and maybe some different considerations for medications, and also bladder. Sorry, I have a cold too. My bad. I'll try to keep the coughing to a minimum, but it's going to come out every once in a while. bladder Botox injections, and we'll talk through what that means and what that looks like. And then bladder sacral neuromodulation, which we'll additionally address here in more detail. So go ahead and go to the next slide. All right, so I already kind of talked about this kind of stuff, and I think, basically you kind of get the concept there that there's certain things that can be irritants and stimulants to the bladder. Go ahead and go to the next slide. I also talked about this, and I think I covered that pretty well. Basically it's just retraining the bladder. So, and that's what PT would do for you. Go ahead and go to the next slide. All right, so medications. So basically everybody has probably seen commercials for and heard about medications related to, gotta go type symptoms and what you can do to take orally to kind of help these symptoms. Basically the bladder is smooth muscle. It can, it's responsive to a nerve stimuli from your brain, and you can actually override some of that by taking a smooth muscle relaxing medication. So antimuscarinic medications are medications that do that. They cause the bladder muscle to not be so hyperspastic and hyperreactive. And there's a lot of different options. There's some that are more generic, that are older. There's some that are newer that work better with less side effects. Many people that take these kind of medications do experience some other smooth muscle relaxing symptoms like dry mouth and constipation and dry eyes. And it's just kind of the nature of the beast with taking a medication that does that in your body. I think that people generally, I would say that there's a lot of people actually that do really well with overactive bladder medications, and it shouldn't be dismissed. But also the caveat there is that, oftentimes insurance companies will give patients kind of a consideration that they're going to ask them to work with their doctor to try a certain algorithm for managing their symptoms before they can get to more advanced therapies. And so oftentimes we will recommend that you trial a certain medication for a time, and then follow back up with us to rediscuss effectiveness. We may consider changing the dose or switching medications or moving on to another therapy. One of the things that Dr. Frank and I both like to use is our patient care pathway for overactive bladder. And it's kind of a little stepwise kind of map that shows you what you've tried and what's next. And so that's something that if you came into the office, we would kind of look at your history, what you've tried, kind of help you build a plan that's so that it's not just let's put you on this med and, come back if you don't like it, or we'll never see you again or whatever. It's sort of, there's a plan, and kind of a stepwise algorithm. And so, I didn't totally, and we can get into this more, but the workup is an important part of this too. And that's something that we really strive to do at the Center for Urinary and Pelvic Health, is provide a comprehensive understanding of the bladder. So it's not just, putting you on a med when you talk to your doctor for 5 minutes about your symptoms. It's, kind of understanding how does the bladder work and why is it doing what it's doing? Is there a relationship to what your bladder's doing and to prolapse, like the uterus falling or the bladder falling? Is there a relationship to, mixed incontinence? And sometimes we'll put patients through certain testing that will help us kind of sort that out. It's called urodynamic testing. It's done in the office, and we really want to strive to be kind of a comprehensive and full service, group that really, helps you really understand what's going on with your bladder and arrives at all of the available and best possible treatments. So I just wanted to kind of take a little sidebar and say the workup is as important as the treatment to get the right answer. So beta-3 agonists, another common brand name is Myrbetriq. It's another type of medication that should have less side effects, but can be very effective for overactive bladder. I do find that some insurances cover this well and some do not. And so that sometimes we run into some issues with cost for patients, but that's something we always help you navigate. So go ahead and go to the next slide. All right, so third line therapy, this is basically referring to when you've kind of gone down that algorithm and, kind of not done as well with certain things that, require you to, or make you think I should go on to another level of treatment here. That's what's called third line therapy. And so Botox, or onabotulinum toxin A, is a medication that's used for lots of different things in the body. It's used for, people think about it as being used to get wrinkles out of your forehead, but it's also used for chronic headaches and trigeminal neuralgia and other things too. And one of the great things that it helps is bladders. And so what we typically do with Botox is it's an office-based procedure. Again, no downtime. The patient is brought in. We would give you sometimes some medications to kind of relax you if you wanted. We would put a numbing gel, a lidocaine gel on the urethra, and we would introduce a small camera into the urethra. And then using a little kind of special needle that's flexible, we can place little tiny bits of Botox across the muscle, the inside mucosal lining layer of the bladder. And what this does is it creates basically it decreases the bladder's ability to be contractile. So it kind of, when the bladder in the brain is telling the bladder to spasm, it just doesn't. It doesn't do it as much. And so a lot of patients find that this is very effective therapy for them for 6, 9, 12 months at a time. Like all Botox, it does wear off over time. And so it does need to be repeated. And so, we always think about kind of having a plan for follow-up and calling us if you're starting to experience mild symptoms again and getting you back in quickly for your next treatment and all these kind of things we would talk you through. But what I find is that most people experience pretty immediate relief within the first day or two after this therapy, and they experience it for quite some time, and they really have no downtime. They can go back to work that same day. So it's a pretty cool concept. The downside to it is that it is repetitive therapy, and there are some considerations for patients, like patients can sometimes have issues with retention of urine. And so we talk through all those things to make sure you're a good candidate for it. One of the things that I think, I'm actually going to skip the last one, peripheral nerve stimulation. There is a concept whereby you can stimulate the bladder by sticking a little acupuncture type needle into the tibial nerve in your ankle, and through a series of several visits for several weeks to the office for about an hour at a time. Is it 30 minutes at a time? An hour at a time. You can experience some relief of your overactive bladder. I think a few people like that idea and are willing to do that, but it is pretty onerous on your time. And so I find that most people are not super accepting of that kind of therapy. And we now have considerably better options for the sacral neuromodulation. Okay. So sacral neuromodulation is a concept where probably the easiest way to explain it to patients is, again, you think of the brain to bladder signal, where your brain's traveling down that neural pathway and telling your bladder to contract. Basically, this therapy introduces a kind of a little bit of a scramble signal to that neural pathway, so that feedback that the bladder is getting is just dampened down, and it's not being as stimulated by that nerve signal from the brain. And so how this works is it's a small implantable battery. It's about the size of a silver dollar, or there's a smaller version that's rechargeable that's maybe the size of a small flash drive. All of these kind of like options and what should I do, what type should I do and everything is something that we would discuss with you in detail and help you arrive at a good conclusion for you. But it's basically a device that can be implanted, and it can provide relief for overactive bladder for 15, 18, 20 years in some circumstances. And so it's a pretty remarkable technology. That battery technology has come a long way in the last 1.5 to 2 years, and is even expanding further. Every day there's new things that we're hearing about batteries and longevity. These devices are now MRI compatible. So a lot of people felt initially nervous that they would not be able to get an MRI if they had to with a metal implant, and that's no longer the case. And really the life of these batteries has dramatically increased and made this a lot more of a acceptable procedure to patients, because they know they're going to get great therapy for a long time. Essentially we would do a test procedure if you were interested in this therapy. We would do an office-based procedure where we place a temporary wire. It's about a 3 to 5 to 7 day test where you wear in a little external battery controller and the wire is removed at the end of the test. And we put you through bladder diaries and voiding diaries to kind of track your progress and success. And if you experience relief with this therapy, then you'd be a good candidate to receive the implant. And so typically we would kind of help you arrange all that, where we would plan the test, plan the wire removal, and plan the implant all in, roughly about a 2-week time frame. And so I'm most excited about this type of technology for patients with overactive bladder, because I've seen, really dramatic success, and also, with the longevity of the batteries now, we're really being able to provide patients with effective relief for a long, long time. So you can go ahead and go to the next slide. So basically, I think I covered all this stuff. Just to recap, the Botox is an in-office procedure, effective duration about 6 to 12 months. The peripheral nerve stimulation is an in-office procedure that involves a small needle in the ankle with weekly therapies, followed by monthly treatments if you respond. And then the sacral neuromodulation is the implanted battery. That's the long-term battery life.
And I just want to jump in with one quick thing.
Yep.
I have had patients where when I talk to them about the sacral neuromodulation, a lot of times the thought of having to do a 2-step process is kind of where I will lose them sometimes. And the way I think of it as, we want to do the peripheral nerve, the in-office evaluation, because we want to make sure it's going to work before we take you to the operating room and do, put you under anesthesia and do the incision and everything and put in the battery. I should knock on wood here, but I haven't had a single patient who hasn't come back after going through the office evaluation to see if it's helpful, and hasn't been like, when can I get this in? Do you have to take this out? Can I get my battery right now? And I would say a vast majority of the patients are usually telling me that they never thought that they could go so long or sleep all night without having to get up or use the restroom, or go on a road trip and they have to stop every hour to use the restroom, and until they had this, and they thought it was just amazing. So I think that's why Dr. Palmer and I are very excited about it, because a lot of times by the time a patient gets to this stage, I don't want to say given up, but they've been through a lot, and they've started to come to the fact that they feel like, oh, I'm just gonna have to live with this. And this one is the one where we get a lot of patients that realize that, oh my gosh, there actually is something that can truly help me. So for us, it's exciting.
Yeah. And I lost my train of thought. All right, go ahead. Go to the next slide. Okay. So that was a pretty fast and furious overview of all things bladder, with the design to try to provide you guys a lot of kind of content and fodder for questions, and really, I think what I want to emphasize too at this point is that every patient is unique, and there's not necessarily a one size fits all program for everybody that feels like they're, if they know their girlfriend or their mom or their aunt or someone had a certain thing done to help their bladder, that may not be the right treatment for you. You may not have to have surgery. You may not, have to have that medication that made your mouth dry, or, whatever the thing is. I mean, it's important to kind of understand that we want to see you, talk to you about your problem, help you comprehensively work it up, and then develop a great treatment plan that's going to be, long lasting and effective for you. That's going to fit your lifestyle. So with that, let's go ahead and take some questions.
So there's a few that were written in here. Should I just read some of the questions?
Do you want to go to the top one?
So someone had asked, they had said that they are overweight and carry most of the weight in their lower abdomen. Was wondering if the sling would be a good option. Assuming that we did an evaluation in the office and found that you had that type of incontinence where the sling would be the best option for you. In my experience, this type of sling, obesity, or having more weight they carry around in the bladder, doesn't affect how well that works, which is one of the nice things for it, because it's really working right at the source of the problem, regardless of how much weight someone may have. And again, that's after doing a full assessment and making sure that, you have the type of incontinence where the sling would help.
Yeah. Right. There's a question about scheduling. I'm not exactly sure what's being asked, but yes, we definitely want to make sure you get scheduled properly, and we'll help you with that.
Yep.
All right. What are the options if you have both types? So again, this is where the the workup comes into most importance. And so a lot of people do have both types, and I really try to talk to people about like bothersome scale and like how is this problem affecting your life, and what's the most significant thing that's affecting your life. So sometimes it makes more sense to correct a defect like a prolapse of the bladder or something, because patients are having symptoms consistent with overactive bladder because they've got kind of a big dropping down of their bladder into the vagina, and that can be corrected with the surgery. And then, maybe it's more related to that than it is to the nerve, brain to bladder nerve problem. So, I think it's, probably the best answer is it's individualized therapy, and we try to figure out what's the most pertinent thing that you're dealing with, and then go after that, with the idea that sometimes you have to kind of, design a therapy that you think is right, and then see what's left with any other symptoms after you're done, and continue to work on it. Sometimes, there's not necessarily a perfect answer, but that's where that individualized patient approach comes in.
Yeah, I think it's a common thing we run into, and it's not a one answer fits all. It's definitely something that includes shared decision making with the patient, and really the two of us, patient and myself or Dr. Palmer, trying to figure out what is the best option and what are you comfortable with and what is going to reach your goal, what bothers you the most. And then the thing I always tell patients to keep in mind is do treat one, and it works really well, and you still have something else. It's not like you can only do one treatment. So that's the other thing that's kind of nice, is there's so many different options that we can often do a combination to get as close as we can to meeting all your goals with all of the different incontinence types that you have, if you have a combination.
Yeah. So going on to the next question, I'm 52 years old. I can't make it to the bathroom in time quite often. I had sling or mesh with Dr. Nielsen 13 years ago. I put on some weight. How do I know if the sling or mesh has failed, or I just have incontinence due to my weight gain? So I think the workup here is a really important part. We have to kind of see you, examine you, and probably this person, you would be a good candidate to have urodynamics, because when you have recurrent incontinence after a sort of a therapy like a sling, it could be that the sling's failed, that your urethra isn't supported anymore, or the sling shifted and isn't in the right place anymore, sometimes due to weight gain. But it also could be a different problem and your sling's working just fine. So the urodynamic testing that's done in the office is really the key to unlocking the answer to that question. And we would definitely be able to help you with that.
Yeah, and yeah, I agree with that. Question about if we need to meet with the physician to talk about our plan, if we already know that they want to go the PT route. I don't know how you feel about this. I feel like it's still helpful for us to be able to do a full assessment and get some idea of what your symptoms are. I feel like it also helps the physical therapist to be able to, because we send her our notes, and then she can see, we've done a detailed question about what specifically are the symptoms that are bothering you, what are your goals, when is your bladder bothering you, how has it been over time, and putting just that whole picture together. We work in collaboration with her often, and so just talking back and forth, it helps us all figure out what's the best treatment, what are the best exercises that's going to help you out the most.
Yeah. And I think that there is, I do have patients that are referred to me after they've seen physical therapy first, or, and I think there is a concept of like direct access to the PT that I wouldn't say there's no per se problem with that, except that it may not be doing what the PT is going to ask you to do, may not actually be the best therapy for you, depending on the workup. And so we just wouldn't want to miss something. But it certainly could be worth trying. And, just with that knowledge in mind that, there may be more to the story than what they can help you on uncover. And when we would want to see you too, to kind of help further. Did we answer that question already about stress and urgency? I mean,
Yeah, there's a lot of questions about stress and urgency. Like we said,
Yeah.
it is really common to have both.
very common. It's
Yeah.
very common.
And sometimes one will cause the other. So if someone has stress incontinence to start, they're going to be going to the bathroom more often because they want their bladder to be close to empty so that they're not, when they do have a leak, they're not leaking so much. And then over time, the bladder learns to hold on to urine less. Not that you're causing it, it's not your fault, but that's just a common pattern that we'll see. And same thing with urgency, they can kind of play off of each other. And so a lot of times, urodynamics is really helpful. And I guess we keep throwing around the word urodynamics. And what that is it's an office evaluation where we get a really good look at the bladder and the muscle and the nerves and how they respond as the bladder gets filled. And that helps us see is the bladder muscle acting and giving you that feeling of having to go without your brain actually telling it that you want to go. And then we have you do some measures to see are you leaking when you're doing things like coughing and laughing. So it gives us a really good detailed look at how the bladder is acting and helping us figure out the best, what's bothering you the most and how best to treat it.
Yeah. And I think we've talked to so many people with these bladder issues that, our job is really to help you sort this all out, and so you may read things on the internet or, you might not know which direction to turn. You might feel like you're just kind of a hot mess, with all these things with your bladder, but that's normal. And that's our job, is to kind of help you figure that out. And so we see people all the time with mixed symptoms, and, that's common, and we'll help you through that.
Okay, I'm trying to see where the next one would be.
Endometriosis and overactive bladder. So yeah, I think that it's the best answer is that it's complicated. Endometriosis is a chronic inflammatory condition. So if you have endometriosis that is between the uterus and the bladder, inside the abdomen, that can create symptoms of urgency and overactive bladder for patients. Even if you've had surgery in the past and had that endo removed, sometimes you can still suffer from a nerve problem related to, just kind of the chronic pain and everything you experience that, needs to be kind of calmed down with some other therapy because you've been dealing with pain and inflammation for so long. So I wouldn't say there's a direct correlation, but I think oftentimes endometriosis patients present to me with a lot of bladder symptoms. And so I always try to kind of think about where does it fit in the context of their other symptoms, and where are they at in their journey with endometriosis and or their bladder, and what makes sense. So yeah, it's common, but we can help you work through that.
One question is how to check to see if a prolapsed bladder is the cause, which is a really good question. And that's something that I think sometimes can be the hardest thing for us to tease out if you have a prolapsed bladder. I tend to, I don't know if we do this differently, but sometimes what I'll do actually is I'll have a patient wear pessary even just for a week, because you should know by then. If that pessary is reducing that prolapse and your symptoms go away, then that tells me, either the pessary will help your symptoms or, surgery to fix the bladder so you don't have to keep wearing the pessary, would also fix your overactive type bladder symptoms. Another thing that I'll do sometimes if people don't want to wear the pessary, which I can understand, that's another place where the role of urodynamics is really useful.
Yeah, because the part of that testing will be to reduce your prolapse and then put you through the measures of trying to fill your bladder and have you cough and sneeze and things that we can see, if it's different with your bladder dropped or with it reduced during that test. I really like the question by Paula. Great success with Botox, but got a different opinion at another clinic. So I think you're going to run into this all the time, and it's worth circling back to, because I would say different providers are going to have different sort of go-to recommendations. Let's say, right? So you do have to somewhat do your own research, but ultimately, if you had success with a therapy like Botox, I think that it could be a reasonably good long-term solution for some patients, so I wouldn't dismiss it out of hand to say that it's going to have long-term side effects, so that's kind of a vague answer, but it's worth following up again, to try to continue to talk about it. And we can help you maybe share some of the things you've read, about the bad experiences that people have talked about on the internet, and then kind of try to put that in context for you, so yeah, it's, I hear that from people though. So-and-so doctor told me, don't do that, it's bad. And you kind of have to try to use the resources in front of you to make the best decision, and that can be difficult, but we'll help you with that.
Yep. And we can give you some websites that can give you accurate information. I'm a Googler too. I know patients always are apologizing for Googling. I'm like, I do it too. I get it. So we can at least give you good places to Google so that you can get good information and, make a good decision.
Yep.
One question about, lots of questions about insurance coverage. I wish we could just tell you like, yes, all it's a combination, and some insurances are better than others. I would say though, I'm usually fairly surprised at how well they can be covered. Now every now and then we'll get one that's not. The procedures tend to be better covered if you've tried something else, but not always. I mean, so we'll have some patients where they don't want to, they know that they want whatever is going to help them the most, and we help with that. Part of what we'll do is we'll check to make sure it's covered, or if it's not, if they need like a prior authorization or documents to say like, this is why this person needs this, then our office will help with that. We can't always just tell you outhand how much it's going to cost out of pocket, but we can help you get the information you would need so you can call your insurance and get that information beforehand.
Yeah. And just rest assured that we're not going to leave you hanging with, not knowing if something's covered. I mean, that, part of the process that we go through with our office and staff is prior authorization and making sure we know exactly what your insurance requirements are before we do any treatment or therapy. So we'll get stuff sent back to us sometimes saying patient doesn't meet criteria. And we have to navigate through that with insurance companies and with patients. But, largely these are covered things because it's not a cosmetic procedure or something. It's a quality of life, and it's a real issue that, has effective therapies. And so it can be, it should be covered by your insurance.
Yep.
And there is a secondary question also there about if you had a sling procedure, if you had it done on Friday, would you be able to get back to work on Monday? I think you had talked about how easy it is, but if you could just address that.
Yeah. I think it depends on the type of work that you're doing. One of the things I usually have people do is that I have them be restricted from heavy lifting for probably a couple weeks, with a mini sling, and maybe long. I would say longer with a different type of sling, but we can help you figure out if that's you or not. But if you're going back to a job where you're not doing a lot of exertional heavy work, I think my experience is that a lot of patients would be ready within a turnaround like that to go back to a non high impact type job by that quickly.
Mm-hmm. I agree. Trying to see where we're at.
This one is, we're wondering if it just needs, if the care can be limited to just the two of you. This person has another doctor that she's seen in Oakdale who's delivered a lot of her babies. She's been through.
Yep. Yeah. So I don't know, I can, if you want to say what you think, Dr. Frank, but I think, it's really important, the doctor-patient relationship that you have with your doctor that you trust. And I definitely wouldn't want to kind of downplay that by any means, because I think that that's a really important thing. But there are certain things that what we've chosen to do within our group, and I think for the benefit of patients, is sort of specialize in certain things, and so not all of the Oakdale doctors most actually don't do the things that we're talking about here tonight to treat bladders. And that's something that Dr. Frank and I have really kind of specialized in and have a skill set in that some of our partners do not. And so I think it would be, I know for a fact that if you asked your doctor that doesn't do these procedures if they should do this for you, they would say, no, you should see Dr. Frank or Dr. Palmer. So I mean, it's really just a question of bouncing something off of them, I think would be great, but you're going to want to be able to be cared for by those of us that do a lot of this work, because that you're going to get the best result.
Mhm. I agree. There's a question about someone who has bladder prolapse and they'll feel the urge to go, which is a common way that you'll get those symptoms if you do have prolapse. But then when they go, they have a hard time getting it out, which probably always sounds kind of like oxymoron. And wondering if it's okay when they displace their bladder, to pass the urine, and that's okay. There's nothing wrong with that. You're not going to harm it. It's not going to cause any issues. Again, that probably would be an indication where we could both probably fairly easily say that it's probably the prolapse that's causing your bladder symptom. Because that's one of the few times where it's fairly straightforward that it's a prolapse issue. But if you're happy with that and that's not bothering you to do that, there's no harm that you're going to cause.
I don't know if we answered your question exactly, Vicky, but there's lots of causes, but I think, probably for many people, it's having babies and it's just a weakness of the pelvic floor. There's people that do like heavy lifting jobs that can be more susceptible to incontinence. People that have other lifestyle things like smokers or diabetics can be more susceptible. So I think that there's maybe not one right answer, but typically we do see, most patients that have incontinence have begun to notice it after childbirth or carrying a pregnancy. And there's a lot of various factors around that as well, but that's, probably just an understanding there's a weakness or a change to the pelvic floor and to the muscles and the nerves of the pelvic floor that are eventually going to lead to this problem for some women.
And then someone else was wondering if they had a previously failed sling, if these treatments are still possible. Yes, the treatments are still possible. I would say we would definitely want to do a very thorough exam to make sure that you still are having, if you're still having the type of incontinence that the sling was treating, there are other types of slings that can help and that we will use for refractory stress incontinence, or if you have some more of a mixed picture, then a lot of these could still be options. So that's the nice thing with there being so many options is, once you've failed something or something has stopped working, it doesn't mean that that's it. It's not the end of the line for you. So that's something that we often will discuss and tease out what's the best option.
Sometimes it's like redoing the sling. Sometimes it's considering like that bulking procedure to kind of provide further benefit for a sling that's not working anymore. Sometimes it's thinking about prolapse, sometimes it's overactive bladder. So there's a variety of reasons why a failed sling would be the case. And I think important to emphasize that just because you tried that, it's still not working for you, it's not the end of the line. There are lots of other things that can be thought through and considered to help you.
Are there any other questions?
Yeah, sphincter issues. Yeah, I mean, so this is kind of a concept of one of the things that causes stress incontinence is a weakness of the urethra, so that it's a little bit open, like open channel urethra. And so, that's more of a type of problem that people experience with the activity type of leakage, but it can also just be like dribbling when you're not even knowing that you're feeling that or something, and your pad's just wet or whatever. So I would say that's probably more of a problem where we look at a certain type of sling or the bulking procedure to address that. But it can be just that alone and not like a pelvic floor problem. So one of the things to sort out with a workup and maybe urodynamics.
All right. We don't have any other questions. So I think with that, perhaps we'll bring it to a conclusion. Thank you very much. I'm sorry the two of you weren't feeling the best, but you did it.
We made it. We made it through.
And Dr. Frank has two sick babies at home as well. So, Anyway,
Got it from.
to those who are attending, you know, make an appointment. You may sit on this for a little bit of time, but know that we're here as a resource for you, and that there are many options for you. So we appreciate you attending and look forward to seeing you at some point in time along your bladder health journey. So thank you, doctors. Thank you, Andy. I appreciate
Thanks,
it.
guys.
Okay, bye-bye.
Everybody for attending.
Thank you, everybody.